হ্যাঁ কোথায়? বাহ, ঠিক আছে।
Sir, good morning.
আচ্ছা, হ্যাঁ ঠিক আছে, ওকে। Good morning, friends. Now we are having the master class of this month, second master class of this month. Sorry, first master class of this month. We'll be talking about, discussing about two interesting case-based cases of RPGN.
Rapidly progressive glomerulonephritis.
RPGN. Our chairperson today is Professor Kanailal Kormokar. He is now attached to Arjikar Medical College and Hospital. Now, Kanai,
Yes,
please
sir.
introduce the chairperson and start.
Good morning, everybody. Thank you, sir, for your initial introduction. I'm really privileged to introduce the chairperson of today, who will start today's this topic. None other than Professor Madam Raichodhuri. She is a teacher of teachers. She is known to everybody, not only the West Bengal, all over India and beyond that. If nobody knows her, it is his or her fault. No need further introduction. And two important cases will be discussed, and I will be happy to coordinate, and I will be in the entire period to listen to these important cases. Let us over to ma'am. Please start this session.
Thank you, Kanai. It's my privilege to join the galaxy of teachers listening to me here. Many of them are teacher figure to me, and many of them are senior and junior colleagues. I'm happy to present in this scenario my students. Dr. Vivek will take first one case of RPGN and will be followed by Priyangini taking the second class. Without wasting much time, I will request Dr. Vivek to share his PPT and start the case presentation.
Good morning, respected teachers. And I'm not, so there's no option yet to attend this. I'm Dr. Vivek Maulik, second year DMPDT of Nephrology in IPGM SSKM. Today, my first case. My patient is a 59-year-old male Muslim from Pingla, West Midnapur. He was admitted in SSKM on 27th of 24 and was examined by me on 20 February of 2025. His chief complaints were headache for 1 month, swelling of body for 20 days, and decreasing urine output for the last 16 to 17 days. He started with complaints of headache, which was around 3rd week of December 2024, which was sudden in onset, persistent, throbbing in character, and global in nature. He took paracetamol for a few days, but there was no improvement in his symptoms. The headache was not associated with any blurring of vision, any abnormal body movements, any tinnitus, weakness of any body part, vomiting, loss of consciousness, any fever, any epistaxis. Next, he went to a local practitioner, and he was found to have very high BP in the range of 200 to 110. He was started on medications daily, and his headaches got relieved or improved. He did a BP recheck at his home, which came to about 150 to 90. After a few days, the patient noticed the swelling in his legs. Initially, the swelling was up to the level of the knees. Later, it progressed to involve the abdomen and then the whole body. The swelling was painless and progressive, and it indented on pressure. It became prominent on the periorbital area and face, especially in the morning, and decreased as the day progressed. There is history of associated decrease in the urine output from 2 to 3 liters per day to around 500 to 800 ml per day, despite he was taking around 2 to 3 liters of oral fluids daily. It was associated with decrease in appetite and nausea. There was no history of any fever, chest pain, palpitations, abdominal pain, shortness of breath, orthopnea, cough mixed with blood. No history of nasal or ear discharges, no oral ulceration, any rash, redness of the eyes, dimmed vision, any joint pain, yellowish discoloration of the skin, loose stool, no history of weight loss, chronic backache, no history of taking any over-the-counter medicines or taking any alternative medications or using fairness cream, Patient went to the local hospital where some routine blood tests were done, and he was told that he had kidney failure and referred to our center. He was admitted to our center and some routine blood and urine tests were sent. He was started on IV medicines and oral medicines, and he also received some medications given in a small saline bottles. He was told that he needs dialysis and was started on dialysis via catheter inserted in the left groin area. After 3 sessions, he was told that he needs a special form of dialysis. At that time, his swelling had decreased and his urine output was still low. He had received around 7 sessions of those special form of dialysis, and patient had undergone a catheter insertion in the right side of the neck. And at the day I examined the patient had a catheter in the right side of the neck and urine output is around 200 to 300 ml per day. There was no past history of any hospitalization or similar complaints. The patient was non-smoker, non-alcoholic, no history of tuberculosis, diabetes, asthma, or any chronic disease. Now, coming to the summary, a 59-year male with recently detected hypertension presented with progressive swelling of the body with decrease in urine output for 20 days. On evaluation, he was found to have deranged renal function, which required initiation of the dialysis. He received some medications in saline bottles. He was started on a special form of dialysis, which he received 6 to 7 sessions till now. Presently, he has a low urine output.
So, Vivek, you are done with your history. From the history, what is your syndromic diagnosis and why?
Ma'am, my syndromic diagnosis is rapidly progressive renal failure. And ma'am, I have kept it as an RPRF because of the temporal association of the days, means the progression of the impairment of the kidney function, which has spread from few days to weeks. For that reason, madam, I have kept it as an RPRF or rapidly progressive renal failure.
Okay, so what are the causes of RPRF? And for the sake of medicine PGs, we are very conversant with this term. For the sake of medicine PGs, please define RPRF and tell me the causes of RPRF.
Ma'am, RPRF or rapidly progressive renal failure is defined by impairment or deranged renal function, which progresses over few days to weeks. RPRF, ma'am, again can be divided, the causes can be divided based on the compartment of the involvement. Like first, ma'am, it is a tubulointerstitial compartment. The causes can be an ATIN, that is acute tubulointerstitial nephritis or acute tubular necrosis, or ma'am, it can be even a myeloma kidney. The classical, it could be the involvement of the glomerulus, which we call as an RPGN, the rapidly progressive glomerulonephritis. In that, madam, there are many causes like ANCA-associated vasculitis or anti-GBM. Or, ma'am, it can be vascular causes. Vascular causes can be, ma'am, a TMA, atherembolic renal disease. Or, ma'am, even it could have certain causes like obstructive uropathy, especially in this age group. That also can be a cause of RPRF.
So when the glomerulus is involved, we call specifically as RPGN. And at the end of history, we can only coin it as rapidly progressive renal failure, since the evidence of glomerular involvement is still missing, which will be provided by urine
examination.
And at the end of physical examination, for a renal examination, urine examination is the must. Urine is the readily available liquid biopsy for us, through which we can compartmentalize the renal disease. So we will come to whether RPGN or RPRF. At this age, I would ask PGs to remember that at this age, among other causes, multiple myeloma remains one important cause, which should be considered down the line in RPRF. And as we are a referral hospital, so we have a bias of diagnosis. So we get quite a few multiple myeloma in this scenario. And what more is important, why we are so much inclined to define that whether it is RPRF, like CKD and RPRF has a difference, that in RPRF, if you take immediate action, you can return back the renal function considerably from dialysis dependence to independence, both the renal survival and patient survival, two outcomes can improve quite a lot. While if you are delayed, we call it missing the bus. If you are delayed in diagnosis, the tubulointerstitial injury progresses to more on IFTA, we call it interstitial fibrosis, tubular atrophy in biopsy. If that is considerable, if you miss the bus, you are delayed in diagnosis, then the patient moves on to the chronic kidney disease compartment, and which will, after few months or years, will add to your dialysis burden. Okay, so we proceed to physical examination, Vivek, and a definitive diagnosis.
Ma'am, on examination, the patient was alert, conscious, cooperative. Height was around 170 centimeter. Weight was 65 kg. Mild pallor was there. Pitting edema was present. Icterus cyanosis clubbing was absent. Pulse rate was 90 per minute, regular. No special character. No radio-radial or radiofemoral delay. All peripheral pulses palpable. Blood pressure was 130/86 millimeter of mercury in the right arm, supine position. Madam, there was no skin changes, no any spots.
Blood pressure was controlled with antihypertensives.
Yes, ma'am. Yes, ma'am. He was continued on antihypertensive. Yes, ma'am. And on fundus, there was grade 1 to 1 or 2 hypertensive changes were there. The systemic examination, madam, was within the normal limit. A catheter was inserted in the right side of the neck. And on dipstick, the protein was 3+ and RBC was positive.
Okay, so what are the systems you looked for involvement, keeping your differential diagnosis in mind?
Ma'am, first in the general examination, I wanted to look towards the skin condition, whether there was any purpura, any nodules, any macules present over there. Next, madam, I went to wanted to look towards the upper respiratory tract first. In the upper respiratory tract, ma'am, I wanted to see whether there was any crusting, any kind of
when you were looking at upper respiratory tract involvement, what diagnosis was there in your mind? Please mention that so other people can follow the multi-system involvement spectrum.
Ma'am, initially,
upper respiratory tract you were looking at with a diagnosis of GPA in your mind.
Yes, ma'am. GPA means I was thinking of ANC-associated vasculitis, systemic vasculitis. GPA was there on my mind. For that reason, ma'am, I looked at the upper respiratory tract findings. In the upper respiratory tract findings, ma'am, there was no crusting, no sinusitis, no tenderness, and there was no history of any nasal discharge or any ear ache or any ear discharge, no deformity, any septal perforation or collapse, no nose deformity. It was not there, ma'am. In the lower respiratory tract also, there was no history of cough or any hemoptysis in blood mixed with cough. There was no, as such, any symptoms like that. Ma'am, also I looked at the other systems included the neurological system also, like there was no sensory abnormality, and sensory means in all the pain, touch, temperature, all were within the normal sense. There was no deficit, madam, and also there was no cardiological system also. I mean, I was keeping a GPA and other vascularities in mind, though there was no history of any myocarditis like features or any conduction abnormalities like transient heart block. He didn't have any of those symptoms. And in the GI system also, ma'am, there can be involvement of mesenteric ischemia causing pain. There could be hematochezia. It was not there, ma'am. So, and also earlier, as I said, the skin was normal. So probably, ma'am, it was only a renal limited disease, which I was, after the examination and the history, I was probably thinking. Initially, ma'am, I thought of all the systems to rule out vasculitis per se.
So your first diagnosis is vasculitis and primary vasculitis. Yes. So what is the classification of vasculitis that you know while you are looking at a patient of vasculitis and trying to touch the etiological spectrum? What are the classification that is in your mind?
And the classification of vasculitis is based on the Chapel Hill Consensus Conference classification. They have classified vasculitis based on the involvement of the vessels. Mostly they have said classified as a predominantly large vessel vasculitis, predominantly medium vessel, predominantly small vessel vasculitis, variable vessel vasculitis, and vasculitis with a single organ involvement, or vasculitis with known systemic involvement, and also, ma'am, vasculitis with known etiologies. In the ma'am, shall I explain? Shall I give an example of all
No,
the?
we will be presenting like a short case. Which type of vasculitis in this case you were expecting? Is it small,
And small-
large, medium?
Predominantly small vessel vasculitis, madam. I was
Small vessel vasculitis, because renal involvement is predominant in small vessel vasculitis. That is why you are thinking that it might be a case of small vessel vasculitis. So,
yes, ma'am.
what is now your differential diagnosis in terms of etiology?
Ma'am, etiologically, my diagnosis first RPRF followed by rapidly progressive glomerulonephritis after the urine test. And in rapidly progressive glomerulonephritis, madam, I would like to keep ANCA-associated vasculitis or renal-limited vasculitis as my first differential diagnosis. Followed by, madam, I would like to keep infection-related immune complex-mediated glomerulonephritis and, ma'am, anti-GBM. And anti-GBM disease.
Continue with
And,
it. Yes.
and also, ma'am, I would like to keep rule out TMA due to malignant
Anti-GBM.
hypertension. Yes, ma'am. Anti-GBM followed by, ma'am, TMA because of the patient had a
So why your
hypertension.
vasculitis is up from IgR, IRGN or anti-GBM disease?
Ma'am, post-immune GN is not as common as maybe an immune complex mediated GN, but ma'am, there is no typical features of IRGN in my patient. Means the patient do not have any history of fever, or the course was not a very rapid course, like an acute nephritic syndrome presentation was not initially there. But ma'am, but like around 10 to 15% of the cases may have IRGN presentation without fever. And also, ma'am, another pointer is that the immune complex mediated GNs are more common in the younger age, though in India, ma'am, the percentage is little higher on the older age also. The post-infectious glomerulonephritis is common in our country, in our setup. So, ma'am, I would like to keep it as a second. And ANCA-associated vasculitis, madam, I would like to keep as a first, because though it didn't have any extra renal manifestation, but ma'am, I was thinking of probably a renal limited disease was there. And anti-GBM, ma'am, I have kept it as a third, though because the presentation was not a very abrupt, like an anti-GBM would initially have, a very abrupt, a sudden decrease in the urine output of the presentation, maybe with RPGN along with hemoptysis. So for this reason, ma'am, I've kept it. And TMA, ma'am, I've kept it because there was presence of hypertension was there, though it was diagnosed at the time only, but still for that, I've kept it. I like to rule out TMA also in this case.
Yeah. So for students, to summarize what Vivek said, that we have kept, if you go on in to see the small vessel vasculitis subclassification, you will get ANCA-associated vasculitis, immune complex vasculitis, and immune complex diseases are more common in our scenario, but still, this age group, this typical presentation, when the acute glomerulonephritis presents, it presents more like an acute AKI-AGN sort of presentation. In anti-GBM also, it's like a bolt from the blue. Within 7 days, the patient becomes dialysis dependent. This patient typically had some prodrome of illness, hypertension manifested, and gradually moved to dialysis dependence over few weeks, which Vivek already mentioned, that when it is weeks to months, we classify it as RPGN. And in urine, when we call it a GN, when in urine, we find proteins as well as dysmorphic RBCs. Dysmorphic RBCs are better identified under which type of microscope, Vivek? Sometimes,
phase contrast.
Yes, under phase contrast microscopes, we can easily see the dysmorphic RBCs. In this age group, you can get some RBCs if the patient does have a prostatomegaly or some causes related to urethritis or so. But when the maximum RBCs are dysmorphic, more than 80-85%, then you can surely say that the origin is upper in the glomerular system, and coming through the whole course, the RBC had become dysmorphic. And more of it is if you get a RBC cast. So RBC originating from up has been cradled into a cast which has originated in a proximal tubule and give you the telltale proof of a glomerular origin of the disease. So we are sure at the end of his physical examination that multi-system involvement, which we may get in ANCA-associated or other like anti-GBM or other immune complex vasculitis, is lacking. It is mostly renal limited, and considering age, origin in Asia, in our countries, we get ANCA-associated vasculitis. Whites and Asians are more prone to have ANCA-associated vasculitis. Like lupus, the blacks, Hispanics, and Asians rather than the whites or Americans. Similarly, racial predominance is such that we, the Asians and the whites, do get ANCA-associated vasculitis more. And such is the effect of environment. If you look at northern side of India, northern sides do have AV reported more than our side reports, a winter predominant area. However, now when going to the ANCA-associated vasculitis, which is your first set of diagnosis, what are the types? Can you attribute any specific type from this history?
I would like to probably keep as a renal limited vasculitis, probably MPO associated, because MPO associated is mostly seen in renal limited disease with around prevalence of around 6.
What is the difference in presentation of MPO associated or PR3 associated renal disease?
Ma'am, PR3 associated renal disease would be a little less abrupt. NP associated disease would be a little more the presentation would be a little more rapid onset, and ma'am, the chance of relapse would be more in the PR3 disease. The chances of relapse of the disease would be a little lesser in the MPO associated vasculitis, ma'am, and there is no as such difference in the management of both. That's all I can think of now.
So to refine his answer a little, MPO associated, when a patient comes with renal limited disease, then we consider that chance of being MPO associated is more. In case of PR3 associated disease, we mostly get PR3 ANCA, and in about 75% cases, we get PR3 ANCA. Sometimes it is up to 90% cases. Only 5% is ANCA negative. And PR3 is more relapsing, involves the upper respiratory tract more. And as upper respiratory tract involvement is there, patients present with hemoptysis, with epistaxis, and both of them are very alarming symptoms. Microscopic hematuria, the patient doesn't recognize for a long time. But a hemoptysis brings from 400 kilometers to your hospital when the patient doesn't get a diagnosis for hemoptysis. So hemoptysis, epistaxis, these are alarming symptoms, brings the patient early to us. So PR3 diseases, upper respiratory manifestations, they come earlier. Their renal disease, when present, are definitely crescentic GN, but might not be that fast, might not be that advanced. Sorry, not fast, might not be that advanced. On the other hand, if it is only renal limited, you know that creatinine is a silent killer. There is no sign of creatinine increase in body, and very minimal signs like azotemia in advanced stage, but develop slowly, they get accustomed to this symptoms. So noticing microhematuria in urine, fraud in urine is little difficult in early stage. So they come to us with more chronic injury. So they are, when we biopsy them, we get stigma of more chronic disease. there. So with that, this patient being of the age of 60 years or so, having manifestation of renal limited disease, we can think, how can you explain the hypertension, Vivek? Usually RPGN patients do not present with hypertension.
Ma'am, being the patient being in 59 years of age, madam, initially I would probably think of it was an undiagnosed hypertension, means a primary or essential hypertension. Though hypertension can
What
be
can be the
present
other
in a
explanation? Yes, I
RPGN.
agree. Yes, I agree. This is an age group for having primary hypertension. What is the other explanation?
Ma'am, it due to GN only volume related, means sodium retention or water retention that
If
could be
he is
decreased.
anuric or oliguric, it might be volume related. Any other explanation? The other explanation is probably this patient has a lot of advanced kidney injury, lot of infarct areas. In this crescentic GN, we have small infarct in the microvascular supply area. So these infarct areas will produce lot of renin. So you will get, in advanced cases, a renin dominant hypertension, which if you are aware about the pathology, you can control the hypertension nicely with ARBs. Your antihypertensive requirement can be met with a smaller dose and smaller number of tapilbadan. So this is the probably the etiology of the hypertension. Usually all RPGN cases, as they are intermediate between AKI and chronic kidney disease, usually present with preserved urine output. So they are not always hypertensive at presentation. This presentation must, all the explanations that Vivek gave, and I added that it might be due to the ischemic renal injury causing renin pour out and a renin dominant hypertension.
Okay, ma'am.
Acha, where we now, Vivek? And what is the
Ma'am,
time?
here,
So how you are going to manage this case? What are the investigations that you would send to reach your provisional diagnosis? And after you tell me the investigations, we will embark upon the
okay, ma'am.
provisional diagnosis.
Ma'am, initially, I would like to stabilize the patient. When the patient came in azotemic symptoms in a volume overload condition, ma'am, I wanted to.
Come to the, yeah, I know. We don't deal it with as a long case. We are dealing as a short case.
Okay.
So tell me, what are the investigations you like to send to exclude other causes?
Okay, ma'am. I would like to do a complete blood count with a peripheral blood smear. Ma'am, I would like to do a renal function test, including the electrolytes, urea creatinine, serum albumin. And ma'am, calcium phosphate also I would like to see. I would like to do a urine examination, that is routine, REME. And also, ma'am, though the urine output was low, if the output had been a little higher, I would have probably done a 24-hour urinary protein, which was also done in this patient, ma'am. Followed by, ma'am, I would have done an imaging like a USG KOB to see the sizes, the cortical echogenicity and the CMD. And ma'am, I would have done CRP procal. I would have done a chest X-ray. And ma'am, I would have sent certain echocardiography I would have done. And I would have...
You have investigation slides. Go to the investigation slides and show us what did you get and how you utilized it to exclude your diagnosis. Exclude your differential.
Yes, ma'am. The first, the day the investigation is seen on 28th of January. The hemoglobin was 8.8, count was 8,700. The urea creatinine, I could see it was very raised. Urea was around 176, creat was 13.4. Ma'am, after that, the second investigation was on 5th of February. The urea creatinine both have come down.
I'm eager to know the peripheral blood smear because that will help me to exclude something. The patient is anemic. You have kept a diagnosis of TMA. What is there in the peripheral blood?
No schistocytes or no reticulocyte.
So you didn't get any thrombocytopenia. You didn't get the evidence of microangiopathic hemolytic anemia in the blood. That is the presence of schistocytes more than 2%, the peripheral blood smear. So,
yes, ma'am. I mean, the urine, RBCs was around 10 to 12, protein was 3, blood positive, and 24 urinary protein was around 2.1 gram. And after that, and in the culture there was no growth. When USG KVP was done, the sizes was
What was the
8.9.
urine volume? What was the urine volume?
Ma'am, that's one fallacy. The urine volume was around 500 ml, 550 ml. That was.
So we need, actually, we need at least 600 ml of urine to
Yes,
excrete all our solute load. More we lose the urine becomes more concentrated, and they may reflect fallacious solute load. It will be more in concentrated urine. Then
ma'am, chest X-ray
I have
echo
a
was
550,
normal. Ma'am,
600 urine output. So I think 2.1 gram is a justified protein that you might consider. So subnephrotic proteinuria, active sediment in urine, both support your diagnosis of a RPGN.
yes, ma'am. Ma'am, after that, I did a immune profile. I have sent the immune profile. In that, ma'am, C3, C4 was normal. ANA was negative. ANA profile was negative. Anti-plateau was negative. MPO, madam, has come out to be positive in high titer. It was 197.82. PR3 was normal. Anti-GBM was again, ma'am, was negative.
So at this point of time, you are sure that it is a MPO disease. So still you want to do a biopsy or not?
Ma'am, as per the latest guidelines, the first would be to commence the treatment because
whether you are interested to do the biopsy or not.
Yes, yes, ma'am. I would like to do a biopsy.
What is the need for the biopsy?
Ma'am, for prognosticating the case, to know if the burden, to see the sclerosis because we have a certain
so what is the
classification
prognostic classification of oncovasculitis on biopsy?
Ma'am, there is a burden classification. Ma'am, it is important because based on the burdens classification, we can prognosticate. Like if the more than 50% of the glomeruli are sclerosed, ma'am, we call it a sclerosed type of the involvement.
Sclerotic,
if more than 50%,
yes.
Sclerotic. If more than 50% of the glomeruli are normal, ma'am, we call it as a focal class. If more than 50% are having crescents, we call it as crescentic class. And madam, if not, then we call it mixed class. So ma'am, based on this, we have a classification which says that the sclerotic class have the worst prognosis and the focal class have the best prognosis. And the mixed class and ma'am, the cellular would be in between.
Focal class has a renal survival of 90% almost. And sclerotic class comes down to 50%. And the number of normal glomeruli in the biopsy and the IFTA in the tubulointerstitial area actually tell us that whether we will be aggressively treating the patient with immunosuppression or we will be restrictive in immunosuppression, giving more care as we give in a CKD patient with see, whenever you are treating an immunological disease, you should be careful not to blow out the patient himself with your burden of immunosuppression. Particularly the elderly individuals are more prone to have infection. So if I had seen this patient did have very few normal glomeruli. In oncovasculitis, the important prognosticator is how many glomeruli are normal. If there are if in a biopsy specimen, only 10% glomeruli are normal, before hammering the patient with high-grade immunosuppression, I would think twice, look at the IFTA. If it is again more than 50%, I should counsel the patient. See, we can take the immunosuppression. If you go on infection side, we will withdraw immediately and go for a conservative CKD care. So,
yes, ma'am.
So for biopsy, what are the investigations you need to give a patient a safe biopsy?
We usually, before in our department, institutional protocol, we do a complete blood count, and ma'am, we do a RFT.
So you look at the P time, you look at platelet count and
PT-INR, ma'am.
Yes.
PT-INR, and we also see the urine for and the culture before doing the biopsy. And also, ma'am, we do a
When
USG
the
screening,
patient does have a high creatinine, you give a dialysis
pre-dialysis to reduce the uremic load, ma'am, to reduce, and the chance of bleeding would be
chance of
less.
uremic bleed. Okay, okay, okay. So how we'll treat the patient now?
Ma'am, as this patient is an MPO positive vasculitis and the presenting creatinine was very high.
You were
Ma'am,
telling even before your MPO results are available, you will start treatment. So
Yes,
what treatment you will give once you are sure that it is a RPGN?
ma'am, first I would like to give a pulse methylprednisolone.
Ma.
Am I audible?
Yes.
Am I audible, ma'am?
Hmm.
Ma'am,
You are-
first I would like to
Yes,
give
yes.
IV pulse methylprednisolone for 3 days, followed by oral prednisolone to continue in oral prednisolone. And then, ma'am, we will gradually taper over few weeks. And ma'am, second line, again, immune suppression, I would like to consider based on the severity of the disease, ma'am, both rituximab and cyclophosphamide can be used in this case, or pulse cyclophosphamide. And ma'am, because the creatinine was very high, than 3.4, so as per the latest recommendation of KDIGO, we would like to consider plasma exchange also in this patient, ma'am.
Yes. So there were 2 trials, a very old trial, which was
Right.
MAPEX trial,
Plexiglas.
and it was a recent trial, which looked at the utility of plasmapheresis. Practically, they didn't reach to a consensus that both the trials, that whether plasmapheresis is absolutely helpful, but a subgroup analysis of Pexivas trial did show that moderate to high creat and high creat patients, like they have 3.4 to 5.7 or more than 5.7. These are 2 groups who were benefited from plasmapheresis. So we still do plasmapheresis whenever a DAH patient comes or whenever a MPO positive patient with dialysis requiring creatinine has come. So, and another thing is, what are the situation you offer plasmapheresis?
Ma'am, we offer plasmapheresis if the patient comes with serum creatinine of more than 3.4, or a patient is having diffuse alveolar hemorrhage with hypoxemia. And also
any other condition when you get a
having,
combined anti-GBM disease?
and yes, ma'am.
Sometimes
And if it's a
yes, with ANCA
double
we
positive,
can get a double positive disease. So in that situation also, we may need to give plasmapheresis. So what
yes,
about the cyclophosphamide and current treatment with rituximab? What is the status? This particular patient, what you will give and why?
ma'am, this patient is MPO positive. Ma'am, there has been a few trials which have taken, which have validated the use of rituximab in relapsing diseases, like for PR3 positive in older and frail patients and those patients who are premenopausal or considered about the fertility issues. In those cases, rituximab would be preferred. Cyclophosphamide, madam, is preferred in those who are having severe disease, more than serum creatinine of more than 4. Those can be used. Ma'am, there is a trial called Ritux-VAS, which has taken means a combination of rituximab with cyclophosphamide. They have given 4 doses of rituximab, 375 mg per meter square for every week, once weekly for 4 doses, and combined with the 2 doses of cyclophosphamide, and then maintained with rituximab. The Ritux-VAS has shown similar efficacy or lower relapse in compared to IV cyclophosphamide alone. So, ma'am, maybe I would like to consider Ritux-VAS in this patient because of
So
both
IV
the reasons.
cyclophosphamide has the potential of getting malignancy in these patients. So we are little elderly patients. We may preserve little consideration about that. And at the same time, the patient is harboring severe disease. So we may go like Ritux-VAS, like treating with first 2 doses of cyclo and then moving on to rituximab for safety purpose. We are not we are using rituximab for 10, 15 years. We are still not aware that what more problem it can give, but it definitely induces hypogammaglobulinemia, which increases the infection risk in these patients, particularly the elderly patients. So,
Yes, ma'am.
in relapsing diseases, there is superiority of rituximab because we need to use recurrent induction therapy with rituximab. And whenever you should mention that whenever we take up the treatment of this ANCA group of diseases, these have a relapsing potential. So always we have an induction as well as a maintenance phase. In ANCA, current management group of ANCA vasculitis, what we have induction with cyclophosphamide and rituximab. MMF is not at par as induction. And in maintenance, previously, which drug you have to use, and now what drug you are using.
Previously, ma'am, azathioprine was mostly used, ma'am, but there have been few trials like Menritson, then Vitazaram, all have shown the superiority of rituximab. So we are now preferring rituximab as a maintenance therapy after achieving induction of remission in ANCA-associated vasculitis.
You may go for several protocols as per several trials given, 6 monthly or 4 monthly rituximab. And the doses also did vary in those trials. So, but all of them had shown 24 months or 48 months requirement of maintenance phase is there. And one more question, and I will finish this case and take up the second case. What is the steroid sparing drug in this disease? Long term,
we can consider
steroid can cause lot of harm. So what is the steroid sparing?
Ma'am, we are using an oral C5a receptor antagonist, avacopan, as an steroid-sparing agent in ANCA-associated vasculitis. There has been a trial, like phase 3 trial called Advocate, which had shown that it can be used, and it has a better proteinuric remission also compared to steroid in around 12 months of time. So, ma'am, we can consider that.
But it is still not available in India.
Yes, ma'am.
And is a very costly drug as well. So
yes,
might be initially we will not be able to use this. But one important point that once you read, it is for PGs, once you read this ANCA vasculitis, you and ANCA vasculitis management, pathogenesis, sorry, you should take note that only the neutrophil priming, bursting, degranulation, and exciting the BT cells in form of immunoreactivity is not the only thing. Later on, it has been revealed that complements are playing a very good role. That is why C5a receptor blockers have come to block this terminal pathway. So I would recommend students of medicine to go to EJKD Core Curriculum 2020 on ANCA vasculitis for a very good summary of disease pathogenesis, the epidemiology and management, and read that. That will give you a very comprehensive idea, and keep on reading and join the DM. So Kanai, please, before completing, if you have anything, if I missed anything important and you want to highlight.
Oh, thank you, madam. It was a very nice discussion and elaborate discussion, because one thing I would just like to say, all my teachers, my fellow colleagues, who are basically, these are one thing we should remember. Whenever there's a chest pain, there's a cardiac emergency is there, people goes to there and take care of it, so that heart don't get damaged or out of function. Similarly, RF is a renal emergency. Whenever there is a sudden deterioration of the renal function, we should think it that how this kidney can be salvaged. So proper care, that means the early referral and management is most important, so that we can prevent the ongoing progress and ultimately eventually patient land to the renal death. That can be minimized by keeping in mind that this is a renal emergency. Then and then the proper treatment and complication of the RPRF can be minimized.
Yes. That is why I was telling, if you miss the bus, you are gone. So Thank you all. Should we proceed to second case or we will take up any question is there?
No. Proceed to second case. We'll discuss later
Yes,
on.
we are getting here.
Question
Priyankini,
answer
you may
later.
start presenting your second case.
Yes, ma'am. Good afternoon, ma'am. Good afternoon, respected teachers and all attendees. I will be sharing my slide. At IPGMR. And today I'm going to present a case of a 22-year-old unmarried female. She hails from Malda, West Bengal, and she was admitted with us on the 19th of February 2025 and examined on 3rd of March 2025. She came to us with chief complaints of pain in joints of both hands and feet for the last 6 months, generalized body swelling for 2 months, nausea and vomiting for last 3 weeks, and decrease in urine output for 10 days. This patient was apparently well about 6 months ago when she started having joint pain that involved bilateral wrist, elbow, ankle joints, along with the small joints of hand and feet, which gradually increased in intensity and was associated with morning stiffness.
Slideshow button.
Sorry, sir.
Slideshow button. Click on the slideshow button.
Yes. Sorry. So this patient, she started having joint pain 6 months ago, which was associated with morning stiffness that lasted for about 20 to 30 minutes, improved with activity and analgesics, and there was no associated redness or swelling or deformity of the hands or feet. She also had facial rash that worsened on sun exposure and easy fatigability, intermittent low-grade fever for the same duration. She also had history of painless ulcer over buccal mucosa that was self-resolving. There was no history of excessive hair loss. 2 months ago, patient first noticed facial puffiness around with periorbital swelling that was initially during the morning hours and resolved as the day progressed. Later, it became more sustained and it gradually progressed to involve both the lower limbs, initially up to the level of ankles. Then it involved the body, abdomen, and then the whole body. This swelling was painless and indented on pressure, and it was associated with frothiness of urine. History of any high-colored urine or no history of chest pain, palpitations, orthopnea, any PND, cough mixed with blood, sore throat. There was no history of any nasal or ear discharge, redness of eyes, diminished vision. There was no history of any jaundice, any alteration of bowel habits, any black tarry stools, pain, abdomen, weight loss, and any tingling, numbness of limbs. She did not have any history of over-the-counter medications or alternative medication intake. 1 month ago, she went to the local practitioner and was started on oral medications after preliminary results, blood tests, but there was no improvement in her symptoms. And 3 weeks back, she started having extreme generalized weakness, nausea, along with 1 to 2 episodes of vomiting per day. There was no blood in vomitus, and it was not associated with any altered bowel habits. The view of worsening of symptoms and reduction in urine output from about 2.5 to 3 liters per day to 600 to 700 ml per day, despite similar fluid intake over last 10 days, she was referred to our center, admitted on 19th of February. After she came to us, we sent blood and urine investigations, and she was given IV infusion for 3 consecutive days in small saline bottles, and she underwent renal biopsy. After renal biopsy, she received an injection, which was first dose of which was given, and she was told that she will be given monthly injections for 6 months. Following treatment, body swelling gradually improved, and the day when I examined her, her urine output was 2 liters per day. So, and along with that, there was no past history of similar illness. There was no significant past history, no history of tuberculosis, diabetes, asthma, or any chronic disease. She had regular menstrual cycles with 28 to 30-day cycle interval, but she did report that last 3 to 4 cycles, she had increased blood flow with passage of clots. There was no family history of similar illness. So to summarize, this was a 22-year-old female with no prior comorbidities, and she was admitted with bilaterally symmetrical, non-deforming inflammatory arthritis involving small and large joints of hand and feet of 6-month duration, generalized body swelling along with frothy urine of 2-month duration, nausea, vomiting for 3 weeks, and decreased urine output for 10 days. Along with that, she had facial rash, photosensitivity, oral ulcers, intermittent low-grade fever, and generalized weakness. On evaluation, she was found to have deranged renal function, and biopsy was done, after which she has received treatment with IV infusions and symptoms have improved.
Thank you, Priyangini, for a good presentation. What is the diagnosis, syndromic diagnosis at this stage? And tell me the etiological diagnosis you want to keep.
Ma'am, my syndromic diagnosis is rapidly progressive renal failure because of her symptomatology, duration, and worsening uremic symptoms in the form of nausea, vomiting, decrease in urine output over a period of 10 days. So I would like to keep rapidly progressive renal failure as my first diagnosis.
Okay.
And my
So your syndromic diagnosis is again?
Rapidly progressive renal failure, ma'am. And
Yes.
etiological.
Can you from the history tell me why you will favor in this case RPGN from the history?
Ma'am, she had frothiness of urine, and she first presented with a symptom of joint pain, arthralgia, which was an inflammatory arthritis, and followed by, after a period of 4 months, she started having renal symptoms in the form of frothy urine, swelling of the body, which gradually progressed to anosarca and then decrease in urine output. So it is favoring more of RPGN compared to other causes.
So the association of this multi-system involvement, this age and gender, and the renal involvement pattern, all are pushing you towards a diagnosis of glomerular disease, which has some systemic disease in the background.
Yes, ma'am.
Okay. Okay. Now, about your differential, what you want to keep?
Ma'am, I would also like to rule out IgA vasculitis nephritis, even though IgA vasculitis is more commonly seen in the younger age group, but still, because of multi-system involvement, I would like to rule that out. And apart from that, I would like to keep autoimmune GN, ANCA-associated vasculitis, as another differential. I would like to rule it out also.
Okay. Okay. So go to the physical examination, which may change your differential diagnosis.
Yes, ma'am. On physical examination, patient was alert, conscious, cooperative. Facies was normal. She had height of 135 centimeter, weight of 45 kg. She had moderate pallor, but there was no edema at present, no icterus, cyanosis, clubbing, lymphadenopathy. Pulse rate was 70 per minute, regular. There was no abnormality. BP was 124 by 80 mm of Hg, and temperature was normal. Respiratory rate was 16 per minute. There were no changes in the skin or oral mucosa, and there were no changes of the hair. Fundus also was normal, and there was an IV cannula present on the right hand. On systemic examination, there was evidence of a right-sided pleural effusion in the form of absent vocal fremitus, phony dullness, and absent breath sounds over right infrascapular region. And on urine dipstick, I got a protein of 3+ and blood of 2+.
Okay. Would you like to change after your physical examination? Would you like to change your differentials anyway? You want to remove any, or you want to add any, or change the sequence?
I would first like to keep it as SLE only, because nephritis I would like to rule.
Yes, your maximum probability is SLE. And in your ANCA vasculitis also, you can have musculoskeletal symptoms. Which type of ANCA would have more musculoskeletal symptoms and joint and skin involvement?
EGPA.
EGPA or?
EGPA or MPA?
PR3, no. Sorry, MPO. EGPA and MPO would have skin and muscular involvement, and skin and muscular involvement are more in MPO associated. Yes. And then?
So at the end of physical examination, shall I go to the investigations now?
So how now you will be able to, your first diagnosis is lupus.
Yes.
Tell me how you can use the lupus clinical criteria to make a bedside diagnosis. It was once upon a time we used to make a bedside lupus diagnosis with the help of ACR criteria. Now, what criteria you do follow for diagnosis of lupus and why?
Ma'am, now we use the EULAR ACR 2019 criteria. In this criteria, actually, they have introduced an entry criteria of ANA positivity. So now it is used, now they have introduced this because initially there were a large percentage of patients were found to be ANA negative because of the methodology of ANA. But now since they are recommending ANA by IF method in a titer of 1:80, because the sensitivity of this test is very high, so that is why they have introduced this as an entry criterion, because lot of patients who are ANA negative are now found to be ANA positive lupus. And after this entry criterion of ANA positivity is met, again, they have two domains. One is the clinical domain, where there are 7 organ systems. And there is an immunological domain where there are 3 parameters. So now based on this immunological and clinical domain, a score of more than 10, we can label the patient as a classified lupus SLE. If the patient does not satisfy this criteria, but still there is a high index of suspicion, we can still, if the score does not reach 10, we can label them as a clinical SLE.
Yes.
But ANA has to
So what has evolved over time? Let me go into a little bit of history in one line. The first things were lupus was classified in 1982 when we had the ACR criteria. Then 1997, 11 criteria. We all teachers have gone through. We used to remember those 11 criteria. 4 out of 11 criteria used to be diagnostic, and we diagnosed lupus bedside. Now, to improve the sensitivity and specificity of the diagnostic criteria, ANA has come in because there are many other multi-system diseases who have similar cutaneous involvement, like overlap lupus syndromes, like many other multi-system autoimmune diseases. They have shared some criteria, neurological, musculoskeletal, like ANCA also. So if you have one entry criteria, then probably all these clinical domain will improve upon the sensitivity of the criteria and diagnosis. So that is the reason. The last 2019 criteria is more than 95% specific and sensitive. Yes. Then can you mention one criteria that has more than 10 points in value?
renal biopsy finding of class 3 or 4, it has 10 points.
Yes. So ANA positive and only renal involvement, we see many lupus like that. So that if we get a 3-4 biopsy proliferative lupus, we can directly reach the lupus diagnosis. Even other multi-system involvement is not there. But before excluding, we should look at all hematological system and there are many system involvement, the neurological, the cardiac and pleuropulmonary involvement. So just in this patient, you have mentioned that you have found the area of dullness. Are you suspecting a consolidation or an effusion? Can it be there with a lupus patient?
Yes, ma'am. Lupus patients can have respiratory pleuropulmonary involvement in the form of, most common is pleuritis with or without pleural effusion. In this patient, there was complete stony dullness with absence of breath sounds. So I would like to keep pleural effusion as my first. I would like to keep it as pleural effusion. But lupus pneumonitis can also be seen in patients of SLE, and also patients can have infective consolidation. So that is one area where it is difficult to differentiate from lupus pneumonitis versus infective pneumonitis.
Consolidation. So there is sometimes the clinician is in dilemma that whether the effusion that we are looking at is lupus related effusion or it is a synpneumonic effusion of infection, which burden is always very high in lupus. Lupus patients have Treg cell abnormalities and they are very prone to develop infection, and we use immunosuppression quite a lot. So lupus patients are particularly prone to infection. Pulmonary infections are the commonest, and pulmonary infections they can get which will mimic the picture. How will you differentiate? What are the supports that you would take?
Ma'am, actually, there is a lot of overlap in the symptomatology. As a part of constitutional symptom, patient can have fever if there is
Sure.
ongoing lupus activity, and also in fever in cases of infective etiology. But presence of purulent sputum and despite use of treatment, antibiotic, broad spectrum coverage, also if the patient is having persistent clinical symptoms.
So you can go for a sputum culture, ultimately a bulk culture to exclude imaging with CT. CT imaging then?
Imaging findings as well as clinical follow-up of the patient, we can differentiate between infective and activity, lupus activity.
Sometimes even in effusion, you may get an ANA positivity, but this is not an universally accepted thing, and you may not utter this thing in exam. But that was there in some teaching, that it might, the lupus-related effusion might have some ANA positivity in their effusion as well. So now imaging is one help. We can take sputum culture, we can take bulk culture, and then can reach whether it is a infection plus disease activity or infection alone, and whether disease activity alone. So
fluid analysis, if we do, it will be like exudative in both. So it will not be of much help.
So this patient, can you go to the investigations to show us that what was the picture exactly?
Yes, ma'am. So we did a complete blood count for this patient. The first day, the hemoglobin was 8.2 and platelet count was low on 70,000. Total count was 6,200. Urea was high, 80, and creatinine was 2.56. Patient had a serum albumin of 2.7. Electrolytes, sodium was 131, potassium was 4.8. And on follow-up, after she, like next 10 days, patient had almost similar serum creatinine of 2.5, 2.2 with a urea, downtrending urea 63 and 40. Hemoglobin was 8.2 on the next count, and platelet had improved to 1.1 lakh. And on subsequent count, the platelet count had improved up to 1.9 lakh, and the hemoglobin continued to be around in the range of 8. There was a improvement with treatment of urea to 22 and creatinine to 1.6.
So you have a constant burden of anemia. What are the causes of anemia in lupus? Can you attribute it to lupus or something else?
Yes, ma'am. Lupus per se, it can have most common is anemia of chronic disease, which can be normocytic, normochromic. Apart from that, there can be autoimmune hemolytic anemia, which is mainly born antibody-mediated anemia because of IgG, anti-erythrocyte antibody. Or there can be because of MAHA, that is microangiopathic hemolytic anemia, where we can have evidence of hemolysis along with thrombocytopenia.
But vasculitis is not that common, and you can get this in very bad lupus patients, no?
Yes, ma'am.
Yes, yeah.
Evidence of MAHA.
Catastrophic APLA, like when it is present with lupus, then you get that MAHA type of clinic picture. Then
pure red cell aplasia also.
Pure red cell aplasia, yes, sir. Nutritional is there along with that pure red cell aplasia, and the drugs we use, sometimes immunosuppressants, MMF again can cause pure red cell aplasia.
So disease related and treatment related. These patients are on sometimes on painkillers because of their joint pain. Sometimes they develop ulcers due to steroids and use of NSAIDs. Then they develop, they can become a chronic blood loser in stool. So always, when you find such anemia, with other investigations, send the stool as well to look at the occult blood. And some other medications we use as immunosuppression and treatment, like mycophenolate, azathioprine, which can cause a drop of blood count, along with cyclophosphamide. Cyclophosphamide also can cause in bicytopenia or pancytopenia. So this patient's anemia can be explained by all of these. Have you looked into the exact cause? The renal failure itself can, if advanced renal failure, there will be erythropoietin deficiency related anemia too.
Yes, ma'am.
Then
In this patient, there was no evidence of hemolysis, like there was no schistocytes in the peripheral smear. It was a normochromic, normocytic smear, and LDH was 257. There was no indirect hyperbilirubinemia, but we did find a direct Coombs test positivity of 3+ in this patient. And apart from that, LFT was normal, ma'am. So we were
yes.
attributing it to either the disease activity per se and with a direct Coombs test positive autoimmune anemia, along with thrombocytopenia.
Okay. So anemia and thrombocytopenia together constitutes one syndrome in lupus. What is it called?
Ma'am, TMA.
No.
We have to rule
Anemia
out
and thrombocytopenia due to lupus. Sometimes it is called Evans syndrome.
Evans syndrome. Yes, ma'am.
Yes. So anemia was there, joint and skeletal involvement was there, and renal involvement was there. So what did you get if you want to, you have excluded the other autoimmune association. Now the IgA one you can exclude only with biopsy. So let's come to biopsy. What is your biopsy finding? Do you have the report with you?
Yes, ma'am. Yes, ma'am.
Yes, please show us.
Before that, ma'am, I'll just this immune profile report shown us.
Okay, you haven't talked about immune profile.
Yes, ma'am. So
Then please talk about, yeah.
her C3, C4 both were low. C3 was 17.5 and C4 was 6.32, and dsDNA was high at 877. ANA was 3+ force spectral pattern, and rest of the ANA profile was negative, and MPO PR3 was negative, and also negativity of anti-GPM. And next, coming to the renal biopsy, on light microscopy, there were 30 glomeruli, out of which 3 were segmentally sclerosed. 27 glomeruli and non-sclerosed stuff showed enlargement, diffuse and global mesangial hypercellularity, matrix expansion with variable number of neutrophilic infiltration in all glomeruli. That was segmental endocapillary hypercellularity in 4 glomeruli. And GBM showed diffuse, global, and uniform thickening with segmental spikes and holes identified in JMS stain. There was irregular thickening of GBM with prominent double contouring and subendothelial fusionophilic deposits, wire loop lesions seen in all glomeruli.
Okay.
Tubules, vessels, and interstitium was unremarkable, and IFTA was nil. On the IF, there were 18 glomeruli, and it showed a full house pattern. There was IgG 3+, IgA 3+, IgM 1+, C3C 2+, and C1Q 2+. Granular mesangial and capillary wall deposits, and extraglomerular immune complex deposits were also seen.
So it is a full house IF. We call it a full house. We see almost all immunoglobulins positive over there, isn't it?
Yes, ma'am.
So,
yes.
So just students who are listening to this, medicine students, just remember that the previous case was all immunological, IF was absolutely negative. So it was called a posse-immune GN, and it is, lupus is a full house. Priyangini, can you mention one type of lupus disease which is not still included in the lupus biopsy classification, which is IF negative?
Lupus podocytopathy, ma'am.
Yes. So what is it? What do you see in biopsy of lupus podocytopathy?
Ma'am, MCD, minimal change disease, or FSGS-like pattern.
First, you mentioned that it is a ANA positive lupus with proteinuria. Sometimes they come with very high nephrotic range proteinuria, and they are ANA positive. So we call them lupus. Then
ma'am, on this, in these patients, if we're doing biopsy, then we will not find the biopsy to be matching with any of the profile as given by IS and RPS, and the patients will be having MCD-like or FSGS-like changes on the biopsy.
so light microscopy, either no changes or FSGS-like focal sclerosis with mild or minimal mesangial proliferation. Then IF is?
IF is negative, ma'am, in those patients.
Absolutely negative. And they respond excellently to steroid alone. They, like MCD or FSGS, they respond to steroid alone. That's why the pathologists are little in dilemma to include it in typical lupus ones. The pathogenesis is expected different. It's just podocytopathy rather than an involving the whole immune system. Yes. So, looking at the biopsy, what is your decision? Usually when we see a lupus biopsy, what are the things we concentrate upon? How it influences our treatment of the patient?
So, ma'am, we see the class of lupus, which class of lupus it is, and combined with the presentation, this RPRF, RPGN presentation in this patient, along with the biopsy finding of class 4 plus
Yes,
5.
yes. Other than that,
Other
the
than that,
activity and chronicity. Tell us something about activity and chronicity. What we look at the biopsy and take decision accordingly.
ma'am, and the activity and chronicity index is given by the modified NIH activity and chronicity score. In the activity index,
Yes,
actually,
yes.
2 scores are given, double points. That is, first is the cellular or fibrocellular crescent, and the second is the fibrinoid necrosis. Apart from
Yes.
those two, we also look at the endocapillary hypercellularity, neutrophilic infiltration or carrier X-rays, presence of any interstitial inflammation, and so we look at these and we score the system. The total score is 0 to 24 from on the activity index, and the chronicity parameters we see at the fibrocellular crescent, the total glomerulosclerosis, the combination of both global and segmental, the interstitial fibrosis, and the tubular atrophy. And the
Yes.
total chronicity index is 0 to 12. So
if the chronicity index is too high, if the burden is too high, we are little reluctant to use a very high grade of immunosuppression. So very advanced disease, creatinine, after multiple relapses, they come on sometimes. They come with an exhausted. This patient, IFTA is nil. So we will treat, gets less relapse. So how you want to treat this patient?
ma'am, in case of this patient, first, because she has come in with an RPRF, RPGN kind of presentation after the urine dipstick, after ruling out any infection, we will first give IV methylprednisolone pulse dosage. So in the KDU, they have mentioned 250 to 500 mg IV OD for 3 days. But in our institute, we give 500 mg for 3 days. They have mentioned like a range of 1 to 3 days, followed by oral prednisolone that we will start.
So what protocol you have used in cyclophosphamide use? What are the protocols available?
Ma'am, there are 2 protocols. One is the NIH, modified NIH protocol, and another one is the Eurolupus protocol. In
Yes,
one
yes.
case, we have used the modified NIH, where we give 500 mg to 1 gram per meter square dosage every monthly for 6 months. In our institute, we use a dose of 750 mg per meter square. And if the creatinine, if the eGFR is less than 30, then we will reduce the dose by half. And in the Eurolupus regimen, we give 500 mg fixed dose IV, and that one is the mg per meter square body surface area based. In Eurolupus, we give 500 mg IV doses 15 days apart, and that is 6 doses. That is over a period of 3 months.
Okay. So among these, you are going to give the NIH, modified NIH regime.
Yes, ma'am.
Okay. Suppose your patient has responded nicely, improved urine output. Suppose this patient did not improve. The patient, even after 2 or 3 doses of cyclophosphamide or 3 months on cyclophosphamide and steroid, the patient did not show a good response in terms of creatinine decrease or proteinuria decrease. So renal remission is not there. What you are going to do?
And if renal remission is not there, we have to wait for a period of 3 to 6 months, but we can individualize treatment as per KDIGO also. Then if the patient is having refractory lupus, then we can give a trial of rituximab. Sometimes they have also tried IVIG for such patients in cases of refractory lupus.
Is rituximab is commoner or something else you go for? What are the other 2 things that you try in lupus? You go for the induction therapy. You have 3 choices
yes,
other than rituximab. Sandwich rituximab. Rituximab alone didn't give very good result. So what are the three options?
The three options, ma'am, in the initial treatment is in the induction phases. MMF we can use. MMF in the dose
Yes.
of 1 to
So
1.
MMF at right dose. Induction should not be just 500 milligram 2 tablets. So induction would be
1 to 1.5 grams BD. So total of 2 to 3 grams.
yes.
dosage.
So 2 to 3 grams as per several induction protocol, particularly the ARM study that have looked at MMF comparing the cycloinduction that had reiterated that use of MMF in the 2 to 3 gram range can give good result in Asian lupus. The Asian subgroup did do better in ARM study. Okay, so MMF is one. And what is the other one that we also use?
Ma'am, we also use multi-targeted therapy. That is, we can use a
Yes.
calcium urine inhibitor along with the MPA, that is MMF, along with steroid. Amongst the calcium urine inhibitor, we have availability of tacrolimus as well as cyclosporin, less commonly used. But in trials, they have also recommended usage of voclosporin based on Aurora trial.
Yes. So multi-target therapy can help, we know that in lupus pathogenesis with B cell autoreactivity, there happens a lot of T cell involvement as well. So like a multi-pronged therapy, we use MMF plus tacrolimus, which can minimize the individual drug dose burden and individual drug-related toxicity. If we combine three, the remission achievement is better. Which component is most satisfactorily improved in tacrolimus mycophenolate steroid regime? The multi-drug
high-grade proteinuria.
High-grade proteinuria, if it is present, that responds to the tacrolimus with its local action as well as immunological action that it does have. So these are the three induction regimes. Along with that, what is a new drug that has been approved by FDA for treating lupus in induction?
Ma'am, belimumab has been approved.
Yes. So we are looking at MABs in every field. So rituximab didn't do well. It has some isolated case reports or case series where they did well. But whenever rituximab was tried in RCT, rituximab didn't give a singularly good result in lupus. So as you were mentioning, in refractory severe lupus, we are not finding any way out. We sometimes sandwich rituximab and cyclophosphamide, and sometimes we do not. So this much is for induction. What will we use for maintenance? What are the options?
Ma'am, maintenance options are MMF and azathioprine. So what they generally, nowadays we are generally using MMF for maintenance also. Initial induction by MMF, we will follow it up by MMF maintenance. Only in cases when the pregnancy is being planned or patient is intolerant of MMF, then we are giving azathioprine.
We use azathioprine. Azathioprine has other advantages also. For treating your poor patients who collect medicine from your hospital, coming from a 200-kilometer distance, because MMF is not available everywhere. Most of the time, they become defaulters. So, if possible, consider azathioprine as a alternative drug for these poor patients who may fail to reach you every month to collect the MMF. That is recent. So many times they think the disease is no more. I will not go to SSKM to collect my medicines, and they used to get bad relapses. The disease, when comes back, it jumps like a, that is the name where the name is there, the lupus. It comes like a panther, and the disease sits quiet and comes like a panther. What drug is must to reduce the flares? You should not forget anyway.
HCQ, hydroxychloroquine, ma'am.
Yes. So counsel the patient that even in the midst of hurry, I miss this patient, this drug in your prescription, you should never stop it. When would you advise to take it, and what precaution would you take when the patient is taking it for a long time?
Ma'am, actually dose recommended is 5 mg per kg per day. So
Yes.
ask the patient at baseline, no need to get any ophthalmological evaluation done. But if the patient is not on any higher doses, but if the dose is less than 5 mg per kg per day, we will do opthal evaluation after 5 years to look for toxicity. But if the patient is having higher dose, or if the patient has GFR is less than 30, or sometimes they say concomitant tamoxifen use, so in those cases, we have to do yearly ophthalmological checkup to.
Okay. And when will you give this? Definitely in the night time, and ask the patient not to come out, because sometimes cosmetic appearance disfigurement is also a negative impulse for this. So, Kanai, over to you. If you feel that you would ask anything more, and
No, madam,
I
thank
think
you. Thank you.
after
Very,
1
very good presentation
1
of the two
PM.
very common cases, and the second one is a very common problem to all. And she described nicely and answered all the question, including the modern treatment. Yes, the lupus treatment updated in last year, KDIGO to the 2024. The article is there. Latest lupus management and approach. Anybody can access that guideline, KDIGO guideline, January issued. 2024 last year. That's all. Over to Dr. Sarkar, please.
No. Kanai,
Yes,
please,
sir.
please see the chat box or questions.
Question. Okay.
Yes.
Interaction
Yeah, there's
কিছু
a
হওয়া
few
বা-
question. No
হ্যাঁ,
question is there, sir.
ওটা করে নাও। নেই, একটাও নেই।
No, sir. No question
এই
is
মা,
there.
আমি
Only to
এত খারাপ পড়ালাম, ছেলেদের কিছু প্রশ্নই হয় না।
না, এত ভালো পড়ালে যে আর কোনো আজকে শিবেন্দু নেই, শিবেন্দু তো কোশ্চেন করে যে না, এগুলো কোশ্চেন
কি
করার
কাণ্ড!
কিছু নেই।
আজকে ওরা কি কম লোক এসেছিল শুনতে?
Vivek Moli and Dr. Priyangani Lohia, they have presented nicely and elaborately both the cases, and starting from the detailed discussion from vasculitis, RPGN, like posse-immune vasculitis, to full house phenomenon in SLE lupus nephritis. And thanks to our chairperson, Professor Orpita Ray Chaudhary, Kanai sir, and Dr. R.N. Sarkar, and also to all our attendees and also all our faculties who attended this session. And thanks to IPCA, who has helped us in this sharing our link today. Thank you all.
না, মাইক্রো
Sorry, Microlab. And our next class of API ICP West Bengal will be on 23rd on next month. Thank you all.
and it will be on pulmonary medicine.